consultation, not necessarily that she cannot have a home birth. You know, if she is on progesterone, she makes it to 37 weeks, there's no reason why she can't otherwise have a birth with a licensed midwife, you know.
Right, I think the concern here is, are we putting overdue burden on the woman?
Well, I want to make sure everyone can say.
I just wanted to say, when we're talking about the cream of the crop versus the not cream of the crop of the crop is not going to refer anyone because it's written here, because the not cream of the crop isn't going to care about any of this anyways. So,
We'll make them.
I mean, part of this document, I assume, is for enforcement by the board. And so if it's in writing, then
absolutely. But like when we're talking about, you know, people who don't necessarily practice the best way, whether they're physicians or midwives, it's having something in writing. I mean, they're not practicing the right way or the best way because they're ignoring.
if it's not on the list, I can easily say, oh, here's the list, and it wasn't on the list, and so, anyway.
I think we have to go back to what does the woman gain in safety by a referral for a physician for a history of a preterm birth that she cannot get from her licensed midwife?
But needing to add required consult because she might choose the consult.
I'm Jill Herman. I'm a NICU nurse and also an HVAC mother. And I think most women who've had a history of a significant preterm birth are not going to be choosing home birth, but if they do, they're well informed and they're often already collaborating with an obstetrician. So it kind of seems senseless.
Actually, and I don't share my history often, I had a significantly preterm baby, and I had no clue in my future pregnancies until I got pregnant that I was going to have problems. So there's a lot that you may be informed of because of being a NICU nurse. But I think one of the things, and I remember one of the things I think as a consumer that you can think is, if a midwife can do something, it must mean it's safe, or the state would not have given the stamp of approval. So you have to remember that not everybody's going to be as well educated as the people in the room. So consumers are looking to you for a certain level of protection.
Right, and it's our job to provide that through good informed consent. But not through creating a regulation that provides for a list of items that a woman must be referred for that doesn't increase the safety of her pregnancy, her birth, or significantly change the outcome and the course of her care. If a licensed midwife, I think the question here is, can a licensed midwife adequately consent a woman to her options if she has a history of preterm birth? That's the question. Can she or can't she? If she can't, then we should be referring. I would argue that a licensed midwife, overall, not just the ones sitting in this room, but most licensed midwives in this state, could adequately consent a woman as to what her options are if she's had a previous preterm baby.
I would also add,
First.
I just want to remind us that the medical board has helped to create a comparison chart of the licensed midwives, the CNMs, and the RNs, and it's reminding us that midwives do have the skills and the ability to make adequate evaluations so that we can refer women in, because our goal is to keep them safe. It is to keep their babies safe, and that has been documented, that we have the skills to do that. So it's not about not knowing whether the progesterone will help or not, and do we have this understanding. It's been documented. All of these students that are going through their school now, they're required to understand. They are tested to understand that they must watch for these things so that they keep these women in the appropriate care when they go outside the course of normal, which is the 37-week mark.
I would also add that having, again, worked with midwives directly for 30 years, I can honestly tell you that you know, and I also work with midwifery students, that they're extremely well educated, they're extremely motivated to give proper informed consent. As a matter of fact, because of the model by which I now practice, which is the midwifery model, and these hour-long prenatal visits, I have much more time to delve into these issues and find these things than I ever had as a very busy clinically run obstetrician. The key to safety is if, right now, I mean, not in this room again, because this room is very collaborative. It's been very enlightening for me, and unfortunately I have to fly. But I wanted to just say that in this room there's a different feeling than the general population of physicians have for midwives generally, and the environment that ACOG puts out. And ideally, if safety is our goal, then it's much safer for physicians and midwives to collaborate. And if we would collaborate and make smooth transitions, it wouldn't necessarily be these doubts in the hearts of obstetricians that that we are giving substandard care. It honors the pregnant woman for us to give smooth transition to them and work together with obstetricians, as opposed to just the assumption that midwives are less trained.
I would really agree with. I mean, it's a great statement. I would agree with that. The whole issue of collaboration is really critical. The issue of informed consent. I mean, I'm not sure why this is different from lupus or cardiovascular disease.
Topic with that. I think the question is a history of preterm birth likely to impact the pregnancy? Do we know the answer to that? Whether it's likely? If there's not going to be, if I strike it, is ACOG going to come back with a study that says this is likely to impact the current pregnancy?
I think it depends on how you define impact. If you mean impact by, is she likely to be a candidate for iron progesterone? Yes, she's likely to be a candidate for iron progesterone. If you say that she is likely to deliver preterm, no, it's less than 50% likely that she will deliver preterm again. So
I would ask the question, is it likely that the consult will make a difference? Isn't that sort of what we're here to decide?
That's not how the statute reads. It's likely to impact the pregnancy. And so, I mean, just as we're sitting here today, right now, I think that would overcome the hurdle that would keep it in.
Well, I think, again, it's correct that it is likely to impact the pregnancy, whereas preterm birth is not, it doesn't have a 50% recurrence rate. But to impact the pregnancy,
right.
That's a different story, and I think the answer is yes.
Okay. I think unless...
I don't think anywhere else we interpreted likely to affect the pregnancy as likely to affect the
treatment
plan.
Yeah.
I think we've only meant it in a like physiological sort of a way, right? I mean, has there been any other point where we interpreted it to mean likely to affect the care plan?
Well, tell me, I mean, there are other...
The statement that I heard from ACOG is that 50% likely to affect this pregnancy, no. Whether or not she is a candidate for progesterone.
It's more than 50% likely that she's going to have to have...
She'd be a candidate
for this particular have another preterm labor. However, she could choose to take progesterone, but that's a choice in her care, which is not whether or not her preterm labor is going to affect this. Her decisions will, but that's her right. And that's not a legislative, Carrie?
I have an analogy on this point. So if we're going to make it likely to affect her course of care because she is a candidate probably for the progesterone, well, then a whole bunch of these other things have to go back in too, because a family history of serious genetic disorders should generate a level 2 ultrasound if the woman wants that, but she may decline it, and it's a matter of informed consent.
And you can order it.
We can order it.
Prescribe the progesterone.
No, but we could refer if that's what she desires. We can consent her to her options, and she can say, "Yeah, I want to know more of that. I'd like to go see the maternal fetal specialist about that particular thing," and then we can generate that referral. But
how many? And you may not know the answer to this, but how many women choose to go on the progesterone?
I mean, from my experience, the vast majority do, because you tell them that there's a medicine that might reduce the risk of recurrent preterm birth. Most women would accept it.
most women in your population, but not most women necessarily in home birth. I'm not saying that it shouldn't be an option for home birth women. It should be, and they should be well consented to that as an option. But to require every woman who's had a previous preterm birth to see a physician seems like a pretty heavy burden.
Okay, Rebecca, Alex, and Dave.
I would just like to say with midwifery care, our 1% preterm birth rate, how many of these women are getting progesterone? How many? It would be
Or possibly
extremely
quite
rare.
a few, because lots of people enter our care in the second or third trimester.
True, but
I know, but it's not on our LMIR. Like, we don't know it collectively. We don't know.
So as a representative of CFAM, we believe that women are autonomous and can consult with their chosen care provider to make the decision that's best for them. If that means having a conversation with a licensed midwife who says, this is an option, would you like to explore that? We can give you a referral. That is enough for most women in our nation and our understanding.
The training for licensed midwives is equivalent but not identical to nurse midwifery, and we have a standard of care. So if the issue is simply consenting, that's an area that's well covered. That anything that comes about as a result of the intake interview that allows me to know that there may be a problem here, then I have to identify what that problem is, and I have to tell the mother what issues, what responses I might take or the medical profession would take, and then it's her choice to carry that out if she wants to. It doesn't seem that that the idea that 30%, that all of these women should get this drug is what the issue is here, having to do with a likely to affect. But that's a different standard.
And it's probably going to turn out to be just okay. But there's a lot of things that were standard of care in the past where medications given to pregnant women that turned out not to be okay.
I'm going to cut this short, because we're not going to make progress on that, and we may be able to make progress on the B list.
So our sign-in sheet, I know it's off track there, but our sign-in sheet is missing, and in order for the transcription. Yeah, I have some. If you haven't signed in, make sure you.
Okay. So now we're looking at the B list. For purposes of section 2507B1A little I of the code, significant disease arising from the pregnancy includes, but is not limited to, clinically significant evidence of conditions such as, we have threatened or spontaneous abortion after 14 weeks. Keep it.
Yeah.
2, significant vaginal bleeding.
Keep it. Do we need a weak qualifier on that? No. Significant vaginal bleeding.
No, we have significant.
Well, I was just thinking of
We have significant.
Persistent vomiting with dehydration. Okay. Protracted weight loss or failure to gain weight. Sorry. Symptoms of malnutrition or anorexia. 5. Protracted weight loss or failure to gain weight.
Looks like it was okay to delete that.
And the phone conversation is okay to delete.
Some women do lose weight for a number of weeks in the beginning of pregnancy, but if they did it because of persistent vomiting with dehydration, that's already on there, or symptoms of malnutrition or anorexia, that's already on there, and usually that problem corrects itself with good midwifery care.
Okay. 6. 6. gestational diabetes uncontrolled by diet. 7, severe anemia not responsive to treatment. 8, severe or persistent headache.
Not responsive to treatment?
Then it's not
Well, that's not persistent.
Oh, sorry.
Should it be? Is that more appropriate, or should it just be severe and persistent headache?
And
Severe, persistent.
Okay. Severe, persistent headache.
yeah.
Thank you, doctor. 9, evidence of pregnancy-induced hypertension or preeclampsia. 2 blood pressure readings greater than 140 over 90, 6 hours apart.
Yeah.
10, deep vein thrombosis.
Yeah.
11, urinary tract infection unresponsive to treatment. 12, pyelonephritis.
Yeah.
13, severe systemic disease.
Maybe that should be significant.
Significant systemic disease.
It already says up in being clinically significant evidence. Does that help?
I was just trying